Okay, today we're going to do an assessment of the respiratory and the cardiovascular system. I have my patient here, Mr. Reggie Jeanneret. We're going to go ahead and get started. First thing I'm going to do is take a history of my patient for his personal history. Mr. Jeanneret, have you ever had any wheezing, any asthma, any chest pain or purulent drainage or anything like that?
No.
Any blood tinged sputum?
No.
What about your family history? Is there any history of cancer, for lung cancer or any respiratory infections?
No.
Okay, what about cystic fibrosis?
No.
Okay, have you ever had anyone ever told you ever tested positive for TB?
No.
Or had any positive chest x-rays?
No.
Okay, let's see what their family history, okay, any influenza or pneumonia in your past?
No.
Any recreational drug use?
No.
Tobacco?
No.
Any over-the-counter prescriptions or over-the-counter drugs that you take, like Tylenol or NSAIDs or anything like that?
No.
Okay, what about, never had any asthma, so you don't use nebulizers or any sorts like that?
That's correct.
Once we get a clear history of the patient, we're going to go ahead and start our examination for our respiratory. I'm going to have Mr. Jeanneret turn his back to me. And I'm going to start with the posterior of the back. And I start here. What I'm going to do is look for any deformities of the shape. I'm going to have him inhale and exhale. I'll check for impaired movement. Inhale again. Okay, exhale. Inhale. Exhale. Inhale. Exhale. Okay. While I'm also doing this, checking out his skin, making sure that he's got good color. And with his skin, I'll note if there's any discoloration, if there's any cyanosis or anything, that would give me an indication that he doesn't get very good respirations or cleared oxygen going through. And, you know, just doing a visual inspection of him at that time. So, Mr. Jeanneret, I will be touching you before I do anything. I'll let you know that I am touching you. I would like to listen to your breath sounds. If you will open your mouth and inhale. Exhale. Inhale. Again. You can breathe normal. Okay. If you will, say the word 99.
99.
Again.
99.
Okay. Once again, I'm going to look, listen, and feel. I'll check here. I'll do an indirect and a direct percussion measure. And direct. If there's any noted pain here, that would let me know that there was some type of polynephritis or, you know, kidney stones that may be present. We're going to listen to him anteriorly. Turn around. Take a deep breath. Again. Okay, open your mouth and breathe. And again. checking breathing sounds. I'm listening for any advantageous sounds, any wheezing, any rhonchi, listening for crackles, any stridor that may be audible. On inspiration, that would be like a loud pitching musical sound. That would indicate that he would have a blocked airway or object, from an object or swollen tissue. If there was any decreased pitching or braiding sound, that could be a pleural friction rub. And with that, that would be heard on inhalation or exhalation, and it could be from a visceral pleural rubbing against a parietal pleural from inflamed tissue. Okay. I'm going to have you say the word EE.
EE. EE.
99.
99. 99.
Okay. And if you will whisper the word, the numbers 1, 2, 3.
1, 2, 3. 1, 2, 3.
Okay. And those, if there had been a problem there, it would have been noted as a muffled whispering sound. As we check for the breath sounds and everything that we're listening to, make sure that you're listening under clothing. I know when I did the assessment on the back, I was on top of the clothing, so I will listen under the clothing. Open your mouth and deep breathe. And at this time, while listening, I'm checking for any tactile fremitus. It would be heard with a decreased soft voice, and that you would note that in COPD patients or those with a thickened chest wall. If there was increased tactile fremitus, it would be noted with consolidation or fluid that was filling up in the tissue areas or a pneumonia. Once again, as far as the breath sounds that we were listening to, you can have a resonance, and if you're listening for different sounds over the different aspects of the body, one, when you're listening, if you have a flat sound, that would be over a bony prominence, such as your sternum or from a deep tissue of the thigh. Tympani is used when you're listening to the abdomen, and if we were doing any type of resonance, you could have an increased resonance, and that would be heard in patients with emphysema. And then one with a hollow cavity would be heard in pneumonia or pleural effusions, those that have fluid available on the body. We're going to move on over to cardiovascular system. Once again, when you note in the cardiovascular system in a patient, you want to note their skin. His skin is dry and intact. He has good color. When noting in the face, you note around the patient to see if their orbitals or fluid filled. That would be the first place you would notice fluid filling on a patient. Check for cyanosis in the lips, any discoloration, periorbital edema, cyanosis. If there was any anxiety from the patient, most of the time people that are having problems breathing, are not getting good tissue perfusion, they're going to be anxious because they're trying to catch their breath. Okay, Mr. Jenrette, if we were on a bed, I'd have the bed elevated at a 45-degree position, and I'd have him lean back. You want to check your carotid pulse at this time. We're going to check one at a time. Checking for variation of thrills or skip beats. I'm going to listen for a bruit. If a bruit was present in a patient, these sounds would be, if they're audible, that means there's some type of occlusion from that carotid artery. And also, while we're here, we have the patient tilt their head at a 45-degree angle again. We're going to check for jugular vein pressure. You would see an actual pulsing from the side of the neck, or any jugular vein distension, and you would check each side once at a time. We're going to listen for ventricular sounds. Okay, so we're going to listen for our aortic sound, and our marker, pulmonic, Erb's point, tricuspid, and our mitral. Different sounds being heard would be your S1, which would be a ventricular contraction. It would be louder at your apex. Your S2 would be louder at the base, or you would could even hear the ventricular gallop. And those are noted over when you're listening to the 5 key markers. And also doing our cardiovascular assessment, you want to look at the nails for tissue perfusion, for capillary refill. You note if it's greater than any 2 to 3 seconds. I'm looking at the skin again, and it's warm, dry, intact. Also at the same time, you're going to check your pulses, and you can check lymph nodes. And when you check these items, you want to make sure that you're doing them bilaterally. You check one side against the other side. Pulse here. And when you're checking for the lymph nodes, you're checking for any pain or pressure or any swollen nodules in that area. You also have lymph nodes located in the groin area, behind your knees. And while I'm here, I'll check my pedal pulses. Making sure that they are present. And you want to check the feet just as well as the hands. You want to check for color, whether the skin is dry and intact, whether there are any broken out areas. You want to check for any vascular sores. At this time, you'll be checking the legs for arterial insufficiency versus venous insufficiency. In arterial insufficiency, you may have eschar on your toes that are present, where they're not getting good tissue perfusion. They may tell you, as their legs hang off the side of the bed, that they get pain in their legs, and when they elevate them, it makes them feel better. Whereas with venous insufficiency, you'll have swelling or edema, as you may call it. You may have drainage. You can have pulses that could be faint. Whereas arterial, you won't have pulses that are present. And with the venous insufficiency, it could be a dull, aching pain. this concludes my video for respiratory and cardiovascular system.